Welcome back, our fans. Acute gingival and periodontal conditions. Emergencies in periodontal diseases. Acute periodontal diseases. Rapid onset clinical conditions that involve the periodontium or associated structures and may be characterized by pain or discomfort, tissue destruction, and infection. Low frequency of occurrence. 1. Common dental emergencies. 2. Rapid. Negative effect. 3. Severe systemic consequences. 1. Abscesses in periodontium. Localized purulent inflammation of periodontal tissues. Gingival abscess. Sudden onset. Fluctuant rapidly expanding swelling. Within 24 to 48 hours. Red and smooth. Localized. Sometimes painful. Etiologic factors. Microbial plaque. Foreign body impaction, dental floss, impression material. Trauma. Treatment reversal of the acute phase. Simple case. Severe case. Instruction. Reevaluation. Periodontal abscess. A localized accumulation of pus located within the gingival wall of the periodontal pocket. Detectable clinical symptoms. Periodontal breakdown occurring during a limited period of time. Etiology, risk factors. Periodontal abscess. A pre-existing periodontal pocket. In the absence of a periodontal pocket. A pre-existing PDL pocket. Acute exacerbation. In untreated periodontitis. Refractory periodontitis. Spiral pocket. After different treatments. SRP. Surgical therapy. Systemic antimicrobial. Poorly controlled diabetes mellitus. No periodontal pocket. Impaction of foreign bodies. Harmful habits. Orthodontic factors. Alterations of the root surface. Dental floss, orthodontic elastic, toothpick, rubber dam. Biting wire, nail biting, clenching. Inadequate orthodontic forces or a crossbite. External root resorption, developmental grooves, root perforation and vertical fracture. Is the abscess necessarily located on the same surface of the root as the pocket from which it is formed? Because drainage is more likely to be impaired when a pocket follows a tortuous course. Diagnosis. Acute PDL abscess. Pain? Ovoid elevation in the gingiva. Gingiva. Pus expressed from gingival margin with gentle pressure. Palpation. Percussion. Deep PDL pocket or not? Tooth mobility? Systemic manifestations. Lymphadenopathy? Radiographic changes? Tooth elevation in socket. Chronic PDL abscess. Symptoms yes or no? Pain. Intermittent exudation. Slight elevation of tooth. Sinus tract. Pink bead-like of granulation tissue. No systemic manifestations. Radiographic examination. DD. PDL. Vitality? Deep. Swelling and radiographic changes at. Pain is. Localization? Percussion? Periapical. Vitality? Deep. Swelling and radiographic changes at. Question mark. Pain is. Localization? Percussion? Non-vital tooth with deep pocket may develop PDL abscess. Deep PDL pocket extend to apex cause pulp necrosis. Sinus tract from periapical lesion may drain laterally. Small black square, alleviate symptoms. Small black square, control the spread of infection. Small black square, establish drainage. Treatment for acute abscess. Resolving of acute lesion. Before treatment. The patient's medical history, dental history, and systemic condition are reviewed and evaluated to assist in the diagnosis and to determine the need for systemic antibiotics. A. Through pocket retraction. 1. Anesthesia. 2. Retraction of pocket wall with probe or curette. 3. Gentle digital pressure. 4. Irrigation. 5. SRP if small lesion or postponed. B. External incision. 1. Anesthesia. 2. Vertical incision. Use scalpel 15 at the most fluctuant area extending just apically to abscess. 3. Use curette to elevate tissue gently. 4. Drainage and removal of GT. 5. Approximate wound edges with moist gauze. 2. Short-term high dose. Adjunctive systemic antibiotics. For 3 days. 1 gram amoxicillin as loading dose. Then 500 mg 3 times. 600 mg clindamycin, then 300 mg. 4 times. Zithromax 500 mg once daily. 1. Cellulitis, non-localized, spreading. Infection. 2. Deep, inaccessible pocket. 3. Fever. 4. Regional lymphadenopathy. 5. Immunocompromised status. NB, if the lesion is large and drainage cannot be established, root debridement by scaling and root planning or surgical access should be delayed in favor of antibiotic therapy until the major clinical signs have abated. 3. Rinse with warm salt water every 2 hours for the remainder of the day. 4. Periodic application of chlorhexidine gluconate 0.12% oral rinse either by rinsing or applied locally with a cotton-tipped applicator. 5. Analgesics to relieve pain. Treatment for chronic abscess. 1. As PDL pocket SRP or surgical. 2. Instructions as acute and antibiotic may be needed. Surgical treatment is suggested if deep vertical pocket. Furcation defects? Thanks for watching. Support us by likes and subscribes.